Welcome to another session of Critical Care Conversation. Today we are going to discuss about damage control surgery and damage control resuscitation. Now, its goal is initial operation to control hemorrhage and limit contamination rather than a definite repair of all injuries. That is prioritizing physiology over anatomy. Now, indications are high energy blunt abdominal or chest trauma, penetrating abdominal or chest injuries, combined visceral injury with vascular trauma, major intra-abdominal vascular injury. Now, coming to damage control resuscitation, the lethal triad, it's lethal diamond now. It includes hypocalcemia, acidosis, hypothermia, and coagulopathy. The components of DCR include hemorrhage control, permissive hypotension, that is maintaining a systolic BP around 70 to 90 mm mercury. In the presence of head injury, maintaining it above 100 mm mercury. Next is damage control surgery, then hemostatic resuscitation, rewarming, correction of acidosis, early use of Tranexa, that is within the first 3 hours. Then massive transfusion protocol and early use of blood products, tech-based correction, minimize crystalloids to around 1 liters. Now, coming to damage control surgery, it is divided into 4 phases. Phase 0 happens in a pre-hospital setup or in ER. Injury pattern recognition is done. Damage control resuscitation ongoing. Rapid sequence intubation, early rewarming, and immediate transport to the OT. Now, phase 1 occurs in OT, that is immediate exploratory laparotomy within 90 minutes, where they aim for hemorrhage control, limit contamination, and a temporary wound closure, and ongoing DCR is assured. The phase 2 happens in the ICU, where physiological and biochemical restoration is done and sequelae of hypotension-related metabolic failures are addressed, and tertiary survey is done there. There is unplanned reoperation in phase 2. That is 2 indications. One is ongoing bleed in spite of phase 1. Second is abdominal compartment syndrome, where you have to immediately reopen the abdomen. Next is phase 3. That is ensure adequate resuscitation and physiological optimization, after which the patient is taken up for a definitive repair and tension-free abdominal closure. This phase is also known as phase 4. Now, coming to complications of DCS, the intra-abdominal infection, fistula formation, abdominal wall hernias. Now, take-home messages, DCR and DCS are associated with improved survival and reduced incidence of complications in polytrauma patients. A properly carried out DCR could even obviate the need for a damage control surgery. Thank you.